Hey guys, this is Dr. Hub. In case you haven't subscribed, please do subscribe for updates. RTA, that is a renal tubular acidosis. Now let's look at its characteristics. So first we move on to the hypokalemic RTA, renal tubular acidosis. So let's look at the hypokalemic variety. So hypokalemic variety, there is again two varieties, that is type 1 and type 2. Now let's look at type 1. So in type 1, the primary defect, it lies in the impaired distal acidification. So there will be a impaired distal calcification, distal acidification. And what will be the plasma HCO3? So when you look at the plasma HCO3, this is going to be less than 15, that is 15 milliequivalents per liter. Now what about the plasma potassium? So plasma potassium is going to be low. This will be nothing but it is low, and it normalizes with the alkalization. So it normalizes along with the alkalization. Now what about the urine pH? So when you look at the urine pH, it will be less than 5.5. This is in type 1. And looking at the urine anion gap. So urine anion gap, this is going to be positive. So the last characteristics we are going to see is the nephrolithiasis or the nephrocalcinosis. So does this occur here? So we are looking at the nephrolithiasis as well as the nephrocalcinosis. So nephrolithiasis or nephrocalcinosis, the answer is yes. So type 1 RTA, it includes this. So next we move on to the type 2. Type 2 also we are going to look at the similar features. So what is the primary defect in the type 2 of RTA? The primary defect, it includes a reduce of the proximal. So there is reduce in the proximal and there is HCO3 reabsorption. What is the plasma HCO3 here? So when you look at the plasma HCO3, so plasma HCO3 is nothing but we are considering it in milliequivalents per liter. This will be 12 to 20. Whereas in type 1 it was less than 15. So what about the plasma potassium? The plasma potassium was low in RTA1 and here also it is low. That is, there is low and is decreased further by alkalization. So it decreased further by alkalization. Next is we move on to the urine pH. So how is the urine pH? So here in urine pH it is greater than 5.3. So it is greater than 5.3 and this is if the serum HCO3 exceeds the tubular HCO3. So we are considering the serum HCO3 to be greater than that of the tubular HCO3. And what about there is also reabsorption threshold. So reabsorption threshold. Next is we look at less than 5.3. So under less than 5.3 is when the serum HCO3 is reduced. So here the serum HCO3, if you see the serum HCO3, it is reduced to levels that can be largely absorbed despite the defective proximal tubule. So they can be largely reabsorbed. So it is largely reabsorbed and despite the defective proximal tubule reabsorption mechanism. So it is largely reabsorbed despite of the defective proximal tubule reabsorption mechanisms. Next, the question arises on the urine anion gap. So in terms of urine anion gap, there is a UAG, that is negative, whereas in type 1 it was positive, here it is going to be negative. Then when you look at the nephrolithiasis and the nephrocalcinosis, so in terms of nephrolithiasis as well as the nephrocalcinosis. So here in terms of the nephrolithiasis as well as nephrocalcinosis, the answer is going to be no. It is not present. Lastly, we look at the hyperkalemic RTA. The hyperkalemic RTA. So here in hyperkalemic RTA, the type, let's look at the type. So here we are looking at the type 4. So this is nothing but the type 4 of the RTA. So here in type 4, this is nothing but it is the most common And what is the primary defect in terms of the hypokalemic RTA? The primary defect is nothing but the decrease in the aldosterone secretion. So there's decrease in the aldosterone which is being secretion. So it is which is being secreted, or there is a aldosterone resistance which is seen. So aldosterone resistance. Now what is the plasma HCO3 level here? So plasma HCO3 level here is going to be greater than 17. And what about the plasma potassium? So when you look at the plasma potassium, so this plasma potassium is going to be very high. So this will be high. And correcting the hyperkalemia alone will improve the acidosis by increasing the ammonium availability. So when you correct the hyperkalemia, so while correcting the hyperkalemia alone, it will improve the acidosis. So it will improve. So what does it improve? It improves the acidosis. So it improves the acidosis and it increases the ammonium availability. Next, we look at the urine pH. So how is the urine pH in this case? So the urine pH will be less than 5.5. And whereas in type 1 RTA, if hypokalemic, we saw it is greater than 5.5. And then the question of the urine anion gap. So urine anion gap here is positive, just like the type 1 RTA, and it was negative in terms of the type 2 RTA, that is hypokalemic. Lastly, we move on to the nephrolithiasis as well as a nephrocalcinosis. So in terms of nephrolithiasis and nephrocalcinosis, here it is, the answer is no, it doesn't have. But we saw it positive in terms of the type 1 RTA, it was positive. To learn and grow daily like this, please do subscribe.